Session is by Dr. Minu Mathen, Senior Consultant, Cataract and Refractive Surgery in Chaitanya Group of Hospitals. He is a stalwart in cataract and very famous for his interesting videos. I welcome you, sir, for your session.
Good afternoon, ladies and gentlemen. Sorry for the satire because I have to go to OPL after this. So can you have my son, and thanks Dr. Sindhu for the invite. And ഇപ്പം സാറ് തോമസരൻ സാർ ചോദിച്ചു അല്ലെ വഴിതെറ്റി വന്നതാണോ എന്ന് ചോദിച്ചു. വഴിതെറ്റി വന്നതല്ല, ലെൻസിനും ട്രോമ സംഭവിക്കാം എന്നുള്ളത് നമ്മൾ മനസ്സിലാക്കണം. ലെൻസ് ഓൾസോ ക്യാൻ ഗെറ്റ് ഇഞ്ചേർഡ്. ഇവിടെ നോക്കിയൊന്നും കാണാൻ പറ്റില്ലല്ലേ? ഓക്കെ, സോ ദ ലെൻസ് ഇൻ ട്രോമ. So I was told we should talk about blunt trauma and penetrating injury. So let me talk about blunt trauma. See, this is one case. Sometimes on slit lamp you may see one edge of the lens, but when you are starting off, on inspection you will see that the whole lens is just on the AVF. All the zonules are gone. So then here there is no point in trying to retain the bag and all those things. So you just need to, we are prepared now. See the flaps which are already made, and we are going in for a glued IOL in the or a scleral fixated IOL in the same sitting. So we do a lens removal in these cases. But some of them, they are attached in most of the places. Here you see 4 to 5 clock hours of zonular loss. So I plug that area of zonular loss with dispersive viscoelastic. That's the first thing we need to do to prevent the vitreous from coming into the anterior chamber during the procedure. After that, you can fill it up with HPMC or whatever you like, so that you can do a capsular rhexis well. And here there is vitreous in the anterior chamber. So if there is vitreous in the anterior chamber, we have to do a limited vitrectomy so that the anterior chamber is clear of vitreous. And then don't keep on aspirating and cutting vitreous. You lose support to the lens which is on the AVF. So here adequate vitrectomy to clear off the anterior chamber, and then do not take the irrigation out. You don't want more vitreous to come into the anterior chamber. And with the irrigation on, replace viscoelastic, dispersive viscoelastic into that area, so that it again plugs that area, so and the later steps can be done more easily. So this case, sometimes you don't see any equator, but then it is very loose because many zonules would have been lost, but most of the areas have sparse zonules. So if that is so, then initiating the capsular rhexis is very difficult. Use very sharp needles. Initiate a small flap, and then try to slowly complete it with the forceps, and then you can support the capsular rhexis margin with iris hooks or even capsular hooks, and then complete the case. And after the nucleus is taken, we can implant the capsular tension ring into the capsular bag. I go through the paracentesis, use the second instrument to guide the trailing end into the capsular bag, and you can implant a single piece IOL into the bag, or nowadays I do a 3-piece IOL into the sulcus and capture it in the rhexis margin. So sometimes the pupil doesn't dilate well, and you don't know that what is the extent of this one. So please do use phenocaine or other intracameral dilating drugs, so that you can dilate well in those areas. So see the area of subluxation which you realize on the table. And here this is the use of capsule hooks. These are long ones with the blunted tips. So this tip can go up till the equator, and it can support the equator. So equator being supported by something, and OVDs or the lens supporting the area of zonular dialysis can assist you for stable bag complex during initial part of the phaco. And later on, we can use CTRs to retain the bag more stably, and for long-term stabilization, this CTR will help. And if it is too large, then you may have to fix it with sutures beyond the scope of this talk, so not showing that. But then IOLs can also be injured. See, this whole bag is injured and it is decentered much. So can't do much. It was initially some kind of a wobbly lens. That's why CTR is already in. So these kind of lenses can be fixed. You need not actually explant the whole thing. So there is no vitreous here. So anterior vitreous face is also filled up with dispersive viscoelastic, and prepare flaps. 180-degree opposite is very, very crucial. And then mark these flaps, and 2 millimeters behind the anterior limbus, you make the bite. You can take a 90 Prolene or even Gore-Tex, and use that needle to pierce the bag now, and it comes out through the other side, and the second part of the needle goes above the bag, and this needle is railroaded out through just like your scleral fixation, and so that loop is there around the haptic optic junction, and the CTR also stabilizes it much more. And it can be done on both sides, and the flaps can be glued or sutured, and the IOL can. While centering, do not tighten the knots initially itself. Make slip knots, and then move it either sides and make it centered, and then lock the knots before you complete the case. Coming on to penetrating trauma, see, this is a very small entry wound which you can see there. But then there is an intralenticular foreign body sitting there. So we stain the capsule, see where the capsule is broken. And you can see there is a area which is not taking stain. Many of these small punctures on the capsule will have an area like that. So you include that area also and go beyond it if it is more central. And then complete the case and see, I've taken it out and seen that is a complete rhexis with a center small slit. And through that, this foreign body has gone into the one. Luckily, it has not gone deeper enough to cut the posterior capsule, and so the rest of the thing is routine. And you do a regular phaco, and then at the end, you can see that is the mark on the cornea, where you can see that the entry point is there. Such a subtle small one through which it can go in. So again, to show you that the cut on the cornea is horizontal, but then see where the break on the anterior capsule is always stained, and see this is a vertical tear. So any way it can present. That is the challenge in trauma cases where everything can be different. You cannot expect something to be routine. And then here again there is an intraocular foreign body and they have to go in. And so here you anyway need to stain. See where the capsule is broken. That is very, very crucial. So before putting in HPMC, stain, because with HPMC it will mix with HPMC and you will not know. And then there is already vitreous there, and I'm using it's a speeded up video. Don't do it so fast. So vitreous is taken with the vitrector, and after vitreous is gone, the same instrument can be used to aspirate this fluffy lens material. There is no nucleus there, it is just fluffy lens. Whatever drops, let it drop, because anyway you're going to do a vitrectomy. So retain anterior capsule. So I have done the whole thing without touching the anterior capsule. After finishing it, we are enlarging the opening centrally and placing the lens in the sulcus, and the VR people will take over. And last, this is an intraocular foreign body, and they are ready with all the stuff. So I see the opening on the anterior capsule and the total white cataract. So here this is in the periphery. So I make a little eccentric capsular rhexis so that the cut on the capsule is beyond the rhexis margin. So retain it there and don't include it. Having an intact rhexis is very, very crucial. Aspirate as much as possible. But here again the pars plana entry is always there. They can do the rest of the lens aspiration. See, before IOL placement, they can even bring the intraocular foreign body up, and we can take it out through the main incision and then place the IOL. And thank you very much.
Thank you, sir. That was an interesting presentation.
So if there is any questions, I can answer right now because I have to go to that hall now.
Any questions from the audience? No, sir. Thank you.
So any case, if you can do an anterior segment OCT, please do. Or an anterior, if you do, you can assess the posterior capsule. But rent with the intralenticular foreign body. Intralenticular foreign body, I will do the case in my OR, my VR surgeon's OR. He will be on standby, and 100% some of the things will drop. It is all luck that it will not drop. Otherwise, it will drop. It is going to drop. These are fresh wounds, and it will take weeks to fibrose at the edge. If there is fibrosis, then it is fine. But if there are fresh ones, they will expand during the surgery, and always expect a drop, and be with the VR surgeon and ask him to continue the case if you are dropped. Don't take it in an anterior segment room.